welcome to another EMKAF session facilitated by Dactario Online. Today we are going to be discussing about electrical injuries. They are not quite common, at least in Nairobi or this side of the country. But if you can remember a couple of years back around Western Kenya, Bungoma, Kisii, Busia, there were quite a lot of cases of electrical injuries, lightning injuries, and the such. Okay, so let's start. Before we get into the meat, we have to know the terms when we are discussing electricity, and we have to know a bit of physics. And this is essentially Ohm's law, which normally says an electric current is directly proportional to the voltage and indirectly proportional to the resistance. Okay, so think of it like this, like there is water flowing down a tube, as the image shows. Okay, electricity by itself is simply just a flow of electrons from one point to another across a concentration gradient, obviously. Voltage, as you can see, think of it like the force that drives these electrons down that concentration gradient. Okay, and then the current itself, which is normally measured in amperes, think of it as the number of electrons that flow through that tube in a second. Okay, so electricity, flow of electrons, voltage, the force that drives electrons, essentially pressure, current, the number of electrons per second. There are a couple of mechanisms of injury when you're thinking about electrical injury, and the common one is direct trauma, like you are electrocuted, you had an electric shock, there was lightning involved. So that the effect of the direct trauma from the bolt of electricity, as it were, can cause injury. Number two, there's what we call tissue damage. Electricity often than not generates heat. So you can get burn injuries. The electrical volt causes generation of heat, or electrical energy is converted to heat energy. And then you cause tissue damage or burns. And thirdly, you can get what we call secondary or mechanical effects. As you can imagine, the force of electricity is normally quite abundant. And sometimes this force can actually cause some secondary injuries, like you're thrown away, you accidentally touch a live wire, and you're thrown away against a wall, or sometimes you're thrown up and you land back down, and you can sustain injuries, fractures, dislocations, cuts, abrasions, essentially any form of trauma, just due to the secondary effects of the electrical volt. Next, what really determines the extent of damage? So there are a couple of things which really contribute to this. As you can imagine, it's not all forms of electricity that actually cause damage. So maybe I can put out a question. What do you think is the difference between electrical, like an electric shock, and electrocution? Anybody? Electric shock, simple electric shock. You are probably in your house trying to connect a gadget to the wall socket, and you used a metallic object, a spoon. You got shocked. Nothing really happened, or you felt some sort of current. Okay. Or think of the Kenya Power employee who is up there doing a bit of maintenance work on the poles, and then accidentally touches a live wire. That's essentially the difference. Electrocution is electric execution, as it were. So it's electricity that causes either a fatal injury or severe traumatic injuries. It doesn't have to be death, you can have severe injury, severe trauma. Okay, you can be thrown about, multiple fractures, arrhythmias, the works. Okay, so there is normally a safe range of exposure to electric currents. There is the range where we can perceive electricity, and then there's a range beyond which the electricity is actually harmful. Okay, so in humans, what we call the threshold of perception is around 0.2 to 0.4 milliamperes. Okay, this is where you just perceive like an electric current, a shock, as it were. Okay, and sometimes I know you've had somebody or stories where somebody was exposed to an electric current and they couldn't let go. So there's a range for this as well. There's a range of what you call the let go current, beyond which your muscles actually become tetanic. They just contract. Your hands, I assume, because most of the injuries are direct to the upper limbs. Your flexors contract so much that you are not able to let go. And this range in an adult is normally around 6 to 9 milliamperes. So remember, threshold of perception, 0.2 to 0.4 milliamperes. Let go current, about 6. So you can do the math. This is quite a lot of current. Okay, so when we exceed this let go current, you get tetanic muscle contractions and you're not able to release. All right, so the first factor that contributes to extent of damage is the strength of the current. Okay, number 2 is voltage. So high voltage electricity will obviously cause more damage as compared to low voltage injuries. Okay. Number 3, duration of contact. So it makes more sense if you are in contact with a live wire for a longer duration, your muscles have contracted, you're not able to let go, the extent of damage will be quite a lot. Tissue resistance again contributes. Tissues that are more, to use the term, hard, like bone, that provide a lot of resistance to the current, will lead to an increase in the extent of damage caused by the electricity. Okay, and last one, which I know there's a lot of, I expect a lot of questions on this, is the type of circuit, alternating current versus direct current. Which one do you guys think is more serious, more fatal? Direct current just means that electricity is generated and it flows in one direction. Think of lightning. Alternating current is a bit different. The current is cyclical, goes and comes back, goes and comes back. Okay, so which one do you guys think will cause more damage, AC or DC? Somebody is mentioning DC. Why? Why DC? Why not AC? A lot of guys are saying DC, DC. We have one AC. So what's the consensus? DC. So remember my initial point, direct current is essentially just current in one direction, all right? It causes a single muscle contraction, and often than not, the victim is thrown away from the source of electricity, okay? Just direct, that's what it means. Alternating current, current is cyclical, goes and comes back, goes and comes back, goes and comes back, okay? So the let go current is much more likely to be reached with the AC current than DC current, therefore making AC current more dangerous than DC current, just because of the tetany that it causes. So you're exposed to an alternating current, your flexors, your forearm flexors, your hand flexors, they are normally more stronger than the extensors. So you flex and you are essentially like unable to release the source of the current, and the extent of damage is a lot because the duration of contact is more. You're exposed to more strength of the current, the voltage is a lot. Okay, so I hope that's clear. AC current, you are much more likely to reach. Let go current, which we said for an adult is anything above 9 milliamperes. Okay. So this is a table that I've just put in here. It essentially just says what I was trying to explain. Around 0.2 to 2 milliamperes, you normally experience just a tingling sensation. And as you go down in the different age groups with the different strength of the current, you are much more likely to experience significant physiologic events. So in a child, obviously, the let go current is a bit lower, it's around 5. In an adult male, it's more than 9. In the adult woman, around 8. Okay. Beyond this, beyond 9, past 10 to 20, you experience muscular tetany. Normally, the muscles that are quite involved are forearm flexors. So you're not able to release. Okay. Beyond 20 to 50, now you experience respiratory arrest, simply because of the same thing. Your thoracic muscles, the big muscles that help in inspiration, expiration, experience tetany. So you get respiratory arrest. Beyond 50 to 100, now you start experiencing arrhythmias. Okay, ventricular fibrillation, your heart is quivering. Your ventricles are quivering, as it were. I hope this is clear. Any questions before we proceed? So threshold current, 0.2 to 0.4, let go current varies depending on age. As the current strength increases, you experience a lot worse physiologic effects. So a simple muscular tetany, skeletal muscular tetany, respiratory muscles tetany, in the end, ventricular fibrillation, and even cardiac arrest. All right, so lightning, direct, indirect. It's there, and you already talked about it. Lightning is instantaneous direct current, okay? Normally, it comes from around 2 million, 10 million, 20 million volts, all right? This is high voltage electrical injury. And lightning can cause injuries in a couple of ways. I'm sure you've heard the stories. The most common one I think I can remember is around 8-9 years ago in Bungoma, where there was a school where unfortunately there was a lightning strike with, if you can remember correctly, 1 or 2 fatalities. And majority of the students were actually hospitalized simply because of the effects of the lightning. So it doesn't have to be a direct strike. Yes, it can happen. You can actually be hit by lightning directly. Okay. It can also be what we call a side flash. It's raining, you're trying to get cover under a tree. The tree is hit by lightning. Eventually, you get what we call a side flash. You're still electrocuted by the lightning. It can be as a result of what we call contact voltage. Your house, your plumbing, your electrical works were not done properly. So there's a lightning strike, hits your roof, hits your TV antenna, and maybe you are touching a metallic object that is in contact with the wall. You get what is called contact voltage. Okay. The other form is what we call step voltage, where lightning hits the ground, bounces back, comes and hits you from below. okay, or you're seeking shelter in a cave, the hill, or whatever vegetables, plants experience lightning, you're somewhere in a cave there, the current flows through the ground and you're electrocuted by lightning. Okay, so these are some of the ways where lightning can cause electrocution. What I need to ask is, when you're hit by lightning, what sort of arrhythmia do you experience, or dysrhythmia? Do you get VFib? Does your heart stop? Do you get pulseless electrical activity, tachycardia? What sort of arrhythmia does lightning induce in the heart? Anyone in the chat? Quick guess. Asystole, VFib, PA, cardiac arrhythmias, VTAC. Anybody else? A lot of you are going for VFib. A shockable rhythm. Haya, wale wa mwisho before tufunge tuseme answer. VTAC. So I'm seeing a lot of people going for VFib, essentially tachycardias. SVT, it's interesting. Atrial fibrillation. Okay. Why atrial fibrillation? SVT, AFib, respiratory, tachycardia, which is just everything. So here is a table that tries to explain that. Okay. When you are hit by up to 2 billion, 1 million to 2 billion volts, your heart is stunned into a systole. Okay. There is no tetany. It's a direct current. It's instantaneous. As systole, your heart essentially stops. Okay. This is different for low voltage. Normally, these are household equipment. Less than 1,000 volts. AC current is common. You experience tetany, eventually ventricular fibrillation, and you can get superficial burns. But because of the low voltage, muscle breakdown and subsequent rhabdomyolysis is not common. In high voltage injuries, either AC or DC, with a brief contact with the source of electricity, your heart again is stunned. Okay, and you can experience deep burns. Muscle breakdown is quite common, so you might experience rhabdomyolysis. Surprisingly, lightning injury, you may or may not experience muscle breakdown. You actually don't even experience tetany. It's very instantaneous, okay? And sometimes you may not even experience superficial burns, but there will be significant tissue damage just because of the strength of the volts. All right. So either of this will cause multisystemic injuries. With lightning injuries, cardiac arrest is normally the primary cause of mortality. Okay, you're hit by directly or indirectly by lightning, you experience asystole and cardiac arrest. That's the most common cause of mortality in lightning injuries. But you can experience arrhythmias, you can experience direct myocardial tissue damage, or eventual cardiac arrest. Okay. So in the chest as well, you can lightning or electrical injuries, use a lot can cause a lot respiratory arrest. And this can be because of the tetanic contraction of the muscles. You can experience blunt chest trauma. Remember the mechanical or secondary effects. You're hit by a bolt of electricity, you're thrown against a wall, pneumothorax, all those things you can get. Okay, it can be because of blunt chest trauma. It can also be because of the electricity actually depresses or causes your CNS respiratory center to dysfunction. The centers in your brain that control your breathing can be affected by electricity, shutting down your breathing, leading to respiratory arrest. Neurologically, CNS lesions are more common with lightning injuries as opposed to PNS injuries, which are more or less what we experience or what is you're much more likely to experience. There is a phenomena called like cheronoparalysis, which you can experience when you are electrocuted by lightning. It's essentially a transient paralysis or paresthesia that can take place when you're hit by lightning. Okay, I think that's very important to know. You can experience spinal cord damage, although this is normally a delayed sequelae or a delayed complication. Maybe you're hit by lightning or you experience electrical shock. And eventually, or a couple of days, couple of weeks later, you present to a facility with symptoms that are mimicking lower motor neuron disease. And everybody is working you up, doing nerve conduction studies, all those things. You present, you're diagnosed with transverse myelitis. Those hard things that you never see. They can be a delayed sequelae of lightning injury. Of course, musculoskeletal injuries are quite common. Fracture dislocation from mechanical injury. Electricity can cause necrosis of the bone. It can induce coagulative necrosis and such. What about cutaneous injuries? Cutaneous or dermatological injuries. We see this. I think this is probably quite common. I've probably seen once or twice. But I think where lightning is quite common, cutaneous injuries are normally seen. These are the most common systemic injuries of electrical shocks or lightning. The first image here is what we call, the term is used to describe this is what we call a kissing burn. You get burns on these creases on your flexor aspect, the antecubital fossa, and sometimes the electric current flows. So you get like an arc, a current arc. Okay. When you see this, you should be alarmed because this is normally associated with quite extensive tissue damage, the underlying tissue. I know superficially it doesn't look as bad. You normally just have a very hyperpigmented lesion, sometimes a bit of tenderness, but there is normally significant tissue damage underlying the skin. Okay. So what I'm trying to say is the appearance of the superficial burn cannot and should not be used to predict the severity of injury. So don't just look at a patient who has this side of burns and you say, this is type 1 burn, it's nothing much, and then you burn. Okay. Appearance of the burn from lightning injuries cannot and should not be used to predict severity of injury. Okay. Your kidneys can experience acute kidney injury from muscular breakdown. So AKI from rhabdomyolysis is quite common. The eye specialist, ophthalmologist, will also tell you some of the sequelae of shock injuries is delay onset cataract. Okay, so you might see a patient who was electrocuted or hit by lightning, and they are fine. Their EKG at presentation is okay. They have no complaint, and rightfully, you discharge them home probably after a period of monitoring, and then down the weeks, down the month, he presents back to your ED with reduced vision, eye pain. Some of them come with the tinnitus or loss of balance. They are experiencing auditory issues. Okay, so electrical injuries normally cause delayed onset cataracts. I see somebody was asking what ocular injury means. It means delayed onset cataract. You can also get tympanic membrane rupture, or the middle ear, the inner ear can be injured. Your, I think it's the eighth cranial nerve, can be injured. Okay, most of these patients, when they present to the ED, some of the things you will notice it's that they are tachycardic, their PPs are high. Somebody might just come and they've passed out, and you're not able to explain. It's because of autonomic dysregulation. Okay, electricity induces, let me say, a sudden catecholamine release, which would explain a transient hypertension. I'm saying transient because it should resolve. Okay, tachycardias, or somebody could just have a vasovagal syncope. This is essentially autonomic dysregulation. Okay, you can get visceral abdominal injuries. The most common site being the colon. You can get colon injuries, stress ulcers. This is quite common. Anybody with burns, direct flame electrical injuries, we normally do prophylaxis, PPIs, just to prevent stress ulcers. I hope the person who was asking about ocular injury, I have answered your question. Anybody else? So, like I said, dermatological injuries are quite common. This is what we call a feathering pattern. You will see this, or if you've seen this with lightning injuries, they normally look like this, like a feather spread out. Okay. And if you can compare with the eye, it more or less appears to have the same pattern. So this is a pathognomonic of lightning injuries, what is the so-called Lichtenberg pattern. Okay. In our African setting with our melanin, it looks like this. To the west, it looks like a tattoo that is yet to heal. Is that clear? So when you see this, if you do see this, this is should be a sign that your patient probably experienced lightning injury. Any questions so far? Anything? Any clarifications, guys? So what happens when these patients come to the ED? They present to your accident and emergency. What happens to this patient? There is a question somebody has asked here. At the point of presentation, is there a way to prevent delayed onset cataract sequelae? I will answer your question. Is there a way? We'll get to it. It's one of my points to discuss, my disposition. So what happens to these patients when they present to your ED? Anybody? Somebody has been electrocuted, electrical shock. They present to your ED. What do you do first? Shoot the answer, shoot the answers. Take vitals, of course, monitoring HDU. If you're lucky enough to have a HDU, fine. ECG, keep warm. What if you already have thermal injury? ECG, ABC, primary survey, hydration, controversial topic. We'll discuss about fluid therapy. ABC is good. So, emergency medicine, tenets of emergency medicine, ABCDE. Lightning injury, electrical injury are trauma and should be evaluated as such. Okay. In fact, I should include a CABCD, a small c. Yeah, if you can imagine a Kenya Power employee doing maintenance work high up in the poles, and they accidentally touch a live wire and they are thrown away. Okay, they land on their back, they land on their neck awkwardly. How are you going to, at the scene, evaluate them? Essentially, this is ATLS, principles of trauma. C-spine and airway, breathing, circulation, disability, exposure. Okay, this is the first thing we do. Electrical injuries are trauma and should be evaluated as trauma. Okay, there are no two ways about it. So the same things you do. C-spine stabilization, airway. Remember, somebody might have been electrocuted in a room and there was subsequent heat energy generated and there was a fire, there is smoke inhalation. Okay. We normally see, unfortunately, some of our open air markets. You wake up in the morning and you hear news of Gikomba was burning, there was a fault in electricity. People were taken to Kenyatta, they were in burn units, some are intubated. So electrical injuries are trauma and should be evaluated as trauma. An ECG is a must. Okay, guys, simply because we need to make sure there is no cardiac arrhythmia, right? Next thing is what you would normally do. You've already done your primary survey. You need to do your secondary survey. Make sure you really look for extensive tissue damage. Okay? When you are exposing this patient, make sure you really examine the patient properly as you would with a trauma patient. Okay? Some might be completely asymptomatic. Okay? And some might come with symptoms, what we call red flags. There is probably a history of loss of consciousness at the scene. There is a documented arrhythmia. Remember, documented. It's not that somebody just passed out and you assume it's asystole. There has to be a documented arrhythmia, okay? Or a cardiac arrest. Or they come in active chest pain, okay? So the way you approach an asymptomatic patient who's undergone electrical injury versus someone who comes in with what the so-called red flags is quite different. The asymptomatic patients more or less end up being discharged after a period of monitoring. If you come with any of the red flags reported or documented, you have to be admitted at least for monitoring. Fluid therapy, fluids, Parkland's formula. Do we use Parkland's formula with electrical injuries? Do we resuscitate the way we do with burns? Anybody? Kennedy amesema no. Anybody else have a different opinion? Somebody is saying Parklands plus 50% maintenance. Why? Why would you resuscitate somebody who's undergone electrical injury based on percentage of body surface burned, which is essentially what Parkland's formula is? They've come in, they don't have any superficial burns at all. They have other injuries. There's some very good questions here. Asymptomatic patient, how long should be monitored for? Good. I'll answer that towards the end. Risk of kidney injury. Titrate fluids based on urine output. So electrical injuries are more or less similar to crash injury. When somebody maybe was in a car accident and one of their limbs was trapped beneath some metallic object, or they were crushed. So think of it like that. Electrical injuries are similar to crash injuries. So these formulas for fluid resuscitation based on percentage of body surface, they're not applicable. Okay. Except maybe there was an electrical injury which triggered thermal injury, somebody experienced a burn, they're coming in with superficial or deep burns, which you resuscitate accordingly as per Parkland's formula or whichever other formula that you use based on body surface affected. Okay, I hope that's clear. The goal for resuscitation, remember, with crash injuries, you will experience muscle breakdown. We anticipate an AKI. Emergency medicine is all about anticipating and stepping forward and preventing. Okay, so you'll put your fluids to prevent AKI, and your goal in fluid resuscitation is based on what? Somebody had mentioned it. Urine output. Okay. Do we need blood tests? Somebody had asked about a full hemogram, hematocrit levels. What do you want to see? Are you interested in the red blood cells, white blood cells, platelets? Are you interested in the white blood cells parameters, the indices, MCV, MCHC? Why would you do blood tests? Kidney function tests, yes, I agree. Electrolytes, yes, I agree. We said lightning causes arrhythmias, or electrical injuries cause arrhythmias. So do you want to do troponins? Or do you want to do creatinine kinase, the muscle breakdown? Will they help you in your management? CKMB, watu wa hospitali kubwa wanafanya CKMB, myoglobin levels, lactate levels, serum lactate. Do you need any of this? I'd probably just say you need your electrolytes. These other things, there is, at least as far as I'm concerned, there is no study that has found any of them really helpful or prevents morbidity or mortality. This is the troponins, the creatinine kinase, the myoglobin levels, all those nice things. There is no science behind it, really. Okay, there's a science for kidney function tests because we are thinking of AKI, secondary to rhabdomyolysis. The science for electrolytes, so that's true. But troponin, CKMB, not really. Okay, I hope that's clear. So you've seen these patients. Who do you admit? Who do you discharge? Who do you monitor? And how long should you monitor them in your ED? Or should you admit them for monitoring? Somebody was mentioning HDU. You don't have a HDU. It's during the strike, man. You are the only one covering the ED. There is no critical care. There is no even ward. Ni wewe. What do you do? So who will you admit? Who do you discharge? Who would you discharge after monitoring? Who would you be concerned about? Somebody wants clarification on fluid therapy. So I will repeat, electrical injuries are more or less like crash injuries. So these formulas for fluid resuscitation based on body surface area, total body surface area, the Parkland's formula and the like, they are not applicable. Okay, except when somebody had an electrical injury, which subsequently caused thermal injury. They were in a house, they were electrocuted, the house caught fire, they got burns, either superficial or deep, which you now resuscitate according to Parkland's formula. Okay, majority of these people will not come with burns. What if somebody comes in with a wound, entrance wound? How do you manage the wound? Do you give antibiotics? Topical, systemic? Do you do closed dressing, open dressing? Maybe they had a cut, they sustained a deep cut. Walirushwa, akagonga, hit his forehead on a hard surface, sustained a frontal scalp laceration, or whichever part of the head of the scalp laceration. How do you manage that? Remember my first point here. Electrical injuries are trauma and should be managed like trauma. Okay? Your fluid to be given is an isotonic fluid, okay? And you titrate it based on urine output. No Parkland's formula, unless there is a concomitant burn. If somebody comes, they were electrocuted, they have lacerations, they have a wound care is essentially what you'd normally do. If it's a cut, if you can repair it, primarily do so. If you think it's infected, you want to delay repair, you want to do secondary repair or involve the surgical team, do that. Okay? Antibiotics. It's a very controversial topic in this era of antibiotics being given everywhere. Tetanus, good point. Anne, I had forgotten that. Trauma, if somebody has not been vaccinated, they've not had a dose of tetanus in the last 10 years, give them a shot of tetanus. Why not? So I agree. Somebody is saying admit for close serial monitoring for about 48 hours. After the 48 hours, you can decide whether to discharge depending on the status of the patient. Okay, so who do you admit, who do you not admit, Sharon? And this 48 hours, it sounds very arbitrary. How did you come up with the 48 hours? Why not 24? Why not 72? Why not 12 or even 6? So what determines 48-hour admission? Anybody? Burns, of course, admit and treat them like burns. Depends with the voltage exposed. I like that. That's a good point. Shaban. To monitor urine output. Okay. You will admit a patient to monitor their urine output. Okay, you may have a point. 24 hours cardiac monitoring by Mr. Vincent. Why not 48 like Sharon was saying? Why 24? Somebody is saying other symptoms may develop within 48 hours. Which other symptoms? This is what I want to know. Why these arbitrary numbers? Is there a science to it? So the truth of the matter is there is really no science. So this is actually left to you as a clinician to determine how long you will monitor somebody, cardiac monitoring, that is. For somebody who came in asymptomatic, had a normal ECG, the history is positive for low voltage injury, you can safely discharge them home. Okay? The period of monitoring is actually left to you. All the science, all the papers you will come across really not mentioning. Everybody is giving arbitrary numbers. The last one I checked was left to you, the clinicians. Essentially, your clinical gestalt is what matters. Okay? So asymptomatic patient, normal ECG, low voltage injury, which you don't expect rhabdomyolysis, you can discharge them. The ones that you really should be concerned about are the ones who had a high voltage injury, lightning, more than 1,000 volts. Somebody who came, or there is a documented history of loss of consciousness on scene. There's a documented arrhythmia. They collapsed, they were resuscitated successfully, and they were brought in. They came in after arresting, and you are still running, resuscitation is still ongoing. They have active chest pain at the time you are seeing them fast. You do an ECG and there are suspect ECG changes, ST elevation or depressions or T-wave inversions, which you can't really quite explain. A new LBBB pattern, and you apply your very complex criteria to determine whether you should be worried about this LBBB. So any suspect ECG changes, admit them. If you have a critical care unit or where somebody can be monitored continuously, well and good. If not, you can do it in the ED if your wards are full. If not, you can do it in the wards. Not everybody has the luxury of having a HDU or ICU or surgical critical care unit. Okay. What about children, pregnant mothers? And for the purposes of this discussion, I would say uh, late second trimester to third trimester. Should you admit them? Why would you be worried about them? Imagine your child, and children normally do this. They're playing in the house, they see a wire, they go touching things, they bite the wire, which is actually quite common. I've seen a couple of these, what we call oral arc burns. So they get burns, their mouth, the inner part, the soft and hard palate, what we call oral arc burns. And these sort of burns, they can bleed significantly. If you've ever experienced a cut in your tongue or in the roof of your mouth, you know how much they can bleed. So in children who have experienced this, you need to admit them. Pregnant mothers, monitor the fetus. Okay, I agree. They can cause placental insufficiency. Yes, I agree. So in addition to the ECG for the mother, what do you do for the baby, the pregnancy? Can they induce labor? Huh? People who have cardiotochographs in their facility, CTG or ultrasound, an obstetric scan. I agree. So for these special populations, it's always, you'll not go wrong by admitting them. And for all of these patients, this is to answer somebody's question. Anybody who presents to your ED after an electric injury, when maybe you admitted them, maybe you monitored them and eventually discharged them, it's always quite good. It's recommended that you discharge them, number one, through cardiology, if you have cardiologists, okay? Especially if they had a documented arrhythmia or suspect ECG changes. They're fine now, they're okay. They've been in the hospital for a couple of days, they're fine now, okay? Everybody who had an electrical injury should be discharged through the ophthalmology clinic and the ENT clinic. This is a must. There are no two ways about this because of what we talked about, the delayed cataract. There's nothing much you can do at the time of initial consult when you're seeing this patient first time in your ED. There's nothing much you can do to prevent this cataract. Like as it is, they're called a delayed onset cataract. It's a known sequelae of a high voltage electrical injuries. Okay. Middle and inner ear complications are also known sequelae. Yeah, even cochlear injuries are known sequelae. So everybody who comes to your ED after experiencing electrical injury, high voltage injury, should be discharged with a follow-up planned with the cardiology team, the ophthalmology team, not optician. Don't tell them to go to Optica, okay? Tell them to go to an ophthalmology center to be seen by an ophthalmologist. And ENT to check their ears. I hope that is clear. This is essentially my last slide. Any question? How much fluid should be given? How do you calculate? Bicarbonates in rhabdomyolysis to prevent acute kidney injury. Interesting. I'll throw the question back to you. The bicarbonate we measure, you do a arteriovenous blood gas or you do kidney function test. Is it the bicarbonate, is it intravascular or intracellular? Is the bicarbonate you measure when you draw blood, is it intravascular or is it intracellular? And when you give it, I'm assuming you're doing it intravascularly. How long do you think it will take to get intracellular? Essentially, is bicarbonate intracellular or intravascular ion? Controversial. I like the different takes because bicarbonate is a very controversial, bicarbonate administration. It's a very controversial topic, even in the science of resuscitation. Okay, somebody has arrested. The cause of arrest is likely metabolic acidosis. You're not even able to measure bicarbonate on your blood gas. So do you give bicarbonate? Whatever I'm going to say is probably my opinion. There's no science to this bicarbonate. Okay, you're better off doing fluids. Target, your urine output is your target. There is no specific amount, like what you do with the, for example, sepsis, where we have what the guidelines on surviving sepsis, which would tell you how much fluid to give per kg. Your target is essentially your urine output. If somebody is having good urine output, you're okay. All right, that's the end of my presentation. Any last minute questions? Let me check the Q&A. Clarifications. What analgesics is recommended? Is an analgesia ladder, which is normally what I answer this question with, unless there is a documented allergic reaction or somebody can't tolerate whatever analgesic you give. Use the analgesic ladder. Start low, go high. Remember, all these analgesics eventually will get to your system. They will work together. Paracetamol, NSAIDs, opioids. Okay. Is OT, operating theater, I assume, follow-up necessary where amputation is done for rehabilitation?
Occupational therapy.
Oh, occupational therapy. Oh, okay. Yeah, it is. Why not? You want to remember occupational therapy is, the target is to return this person to as near as possible of their pre-morbid status. So occupational therapy is okay. Clarity in case of pregnancy. What do you need clarity on? Pregnancy is a special population. Pregnant mothers are a special population. They should be treated as such. Please admit them, okay? In my experience, obstetricians normally are very protective of their patients, okay? They would want you to admit their patient, even if just for monitoring. So you'll never go wrong with admitting them.
I'm seeing a very interesting question from
Yeah.
Joanne Japumbo in the Q&A. If it happens that you're at the lightning scene while it's happening, what are you required to do?
Joanne, if it happens that you're at the lightning scene, what are the things you're required to do? Dr. Jean?
Okay. So always remember, with anything, protect yourself first, right? Do not be a hero. Do not try to save somebody if you're not safe yourself. And also, as even if it's not just lightning, even the electrical injuries, you can become a victim as well. So first things first, make sure you're safe, surrounding is safe, don't be a hero. Number two, I think maybe we've seen it in movies or something. If somebody is currently being electrocuted, you want a neutral appliance to help sort of break that connection, because the flow of current is source through you and then down to the earth, right? So things like neutral sticks that are not wet can be used to detach somebody from the point of electrocution. That's one thing. Another thing, of course, you need to call for help because these people need to go to hospital. So your ambulances. So this is where you can even, as healthcare providers, shameless plug, Casualty app, you can get your nearest ambulance, county ambulance. You can get the contact number from there, call them. And then basic first aid. If they have open wounds, you can, after you pull them to area that is safe, open wounds, you can try and bandage slightly, things like that. Yeah, but make sure you're safe to start with.
I like when you said You've seen it in movies. Joanne, there is a very old movie called, don't ask me how I know this. There's a very old movie called Sweet Home Alabama. If you
Ah.
can watch that movie, at least the first probably 5 minutes and somewhere in between, it will answer your question very well.
Mm.
Sweet Home Alabama.
Okay, great. Right. Yeah, I think most of the questions have been answered as we were going along. I'm just trying to see if there's any question which we have not tackled. Hmm. Okay, there's a question here. With regard to cardiac arrhythmias, if you only have calcium gluconate with you, do you recommend using it? If you don't have any of the rate regulators, verapamil and diltiazem, or beta blockers would be your first choice.
Interesting. It's a very interesting
That's a good
question.
question.
Can't remember the last time I used these verapamils and deltas. And these are CCBs, eh? They are, there's a special classification for them. I forget what it is, but they are calcium channel blockers, if I'm not wrong.
Yeah.
So your question is, would you use this for rate control? Is that right? Anonymous attendee. Are you asking whether you'd use these CCBs for rate control?
So yeah, I think actually, yeah, the question is use of calcium gluconate alone or beta blockers if you don't have your CCBs.
I would have to think about this.
Maybe
It's
you
very
can
interesting.
go back to your slide for the arrhythmias, because we need to remember we said that
the kind of arrhythmias that are caused by.
yeah. So we're thinking about your VF and your asystole. For asystole, of course, you're not giving any medication, right? If it's a VF, what medications are you usually thinking about? So these are not even the ones that we tend to give for the VFs, right? Tend to give the classes were the lignocaines, the
Cardiac lignocaine.
yeah, cardiac
Yeah.
lignocaine. Yeah.
I normally insist that.
Yes, yes. So it's just you just need to remember the type of arrhythmia that you're dealing with. Yeah. Because even in our, if we think about our ACLS algorithm, we don't give any of these, right? If we have a persistent VF and we're thinking about antiarrhythmic medication, we don't give verapamil, diltiazem, right? So I don't think any of those would
We do
be,
not.
yeah, would be ideal. Calcium gluconate, usually we give it as a cardioprotective medication. However, your patient already has the arrhythmia, so you're not really protecting anything. It's usually before you get a cardiac event or a cardiac arrhythmia, right? So unfortunately, I don't think any of those would be ideal.
There is a myth or misconception that you can burn dry grass and smoke on a person who's being electrocuted. Oh, if somebody is actively being electrocuted, do you really think it's a good idea to have an active flame as well? That's probably how I'd answer that. It's probably a myth.
And also, let's always remember everything we're doing nowadays is evidence-based, right? No more herbals, witchcrafts, and the likes. So yeah, I'd ask you, is there really any evidence of that anywhere that you've seen? Yeah. Okay. Right.
Talk about prevention of ocular damage. I would have to ask my ophthalmologist about this. But at the point you're saying your patient, unless the only thing I can think about is probably dry eyes or something, which you can do with artificial tears if you have. Okay, but if you've had a high voltage injury, chances are down the weeks, down the month, you will get delayed onset cataract. So please discharge this patient with and insist on follow-up by the ophthalmology team.